everyone. Once again, welcome to our multidisciplinary grand downs. We have a total of 10 cases today and one follow-up case. We have Dr. Biju and Dr. Pankaj from Ghosh. Also hoping that Dr. Ale also joins us for this session. We'll start off with our first case. If Geeta or Pawan can present the case.
Yeah, this is a 1-year-old male child, sir. We were presented with a motor delay, and there was no sensation in the lower limbs initially, but at present these sensations have improved, and the child started to move his lower limb with pain or stimulus. And on examination, child was having macrocephaly, and there was a significant head lag with frontal bossing, and there was also gibbous, and there is bilateral Achilles tightening and also brisk DTR, and there was a paucity of lower limbs when compared with the upper limbs, and biotedness which was sent was normal, and TMS it was showing elevated leucine and tyrosine which was non-specific, and so it's both central as well as spinal involvement is what we are suspecting. And
All right, we'll move to the images. So the MR and the spine imaging was done a month apart. I think the MR brain was done in May. On top, we have the T2 axial sequences, and you can appreciate that there is some degree of volume loss and some widening of the subarachnoid spaces, predominantly in the frontal regions. And you can also observe that the transcortical vessels are tortuous on both sides, extensive tortuosity of the transcranial vessels. Also in the basal system, there's also again some tortuosity, less predominantly in the posterior fossa, but this entire supratemporal brain parenchyma along the convexities demonstrates these tortuous vessels. Some frontal lobe volume loss and widened subarachnoid spaces, no signal changes within the parenchyma. The T2s, again, you can see that there is a large head with a slightly reduced volume of the corpus callosum and also the brainstem. No atrophy. Again, the coronal images depict the tortuous vessels. No mineralization or hemorrhage on the SWI sequences. The spine was done a month later. And in the spine, you can appreciate that there is some central cord hyperintensity in the cervical spine. And when you see the dorsal and the lumbar spine, it is severely thinned out. There appears to be a canal along the dorsal aspect. On the, I apologize for the pixelated images, but this is the area of hyperintensity along the central and dorsal aspect of the spinal cord. It is within the cord and it is not extending into the dural space. The vertebral bodies demonstrate normal appearance, no Mara abnormalities. So could not come to a definite diagnosis based on the imaging findings. Tortuous intracranial arteries, the differentials one would think of is collagenopathies, connective tissue disorders. Menkes disease is more central or large vessels rather than the vessels along the convexity. Arterial tortuosity syndromes and Lewis-Dietz syndromes are differentials. The spinal cord atrophy, we don't have any images, but they usually can be present post-traumatic or post-myelopathy related changes in the chronic stage can present with spinal cord atrophy. Not sure if the central canal should be termed as a syrinx or not. And at this point, I'll open the case for the panelists for discussion.
Imaging wise, Nihaal, there's nothing to add apart from the fact that we see these prominent vessels in a lot of cases, especially where there is a macrocephaly scenario. The brain, you're right, has lost volume within rather than being a larger brain.
Yeah.
And I think the spinal cord changes would be relevant to what you finally discover in this case. But in terms of calling it a syrinx or hydromyelia, it doesn't matter. There is atrophy, yeah. And I think that's why the central canal is prominent. From your assessment of the spine, I think the vertebral bodies were normal. I don't see any dysplasia there. I hope you agree with that.
No. Yeah,
I'm just trying to get some handles in terms of systemic involvement with some of these macrocephaly syndromes. But I think the 4 options you've shown there, we might probably not get a yes on any of these, to be honest.
Yeah. Yeah.
Because the tortuosity is not in the arteries and Menkes is an intracranial, it would be clinically quite evident as well. So we may not know, and you might find random mutation if you go around searching, but I don't think the radiology is specific in that respect.
What was the reason for the presentation? Well, the presentation was the sensory deficit or the motor delay?
It's a significant motor delay, sir.
And then incidentally, the sensory deficit was found, is it?
Sensory deficit was initially there, sir, but which gradually improved over time. Initially, even when the child is having vaccinations and all, he was not moving much to injections and all. But later on, the child started to move for pain or any stimulus in the lower limbs. And there is a significant disparity in upper and lower limbs. So lower limbs are more significantly involved. And all localization points pointing towards spine, except for there is also a significant head lag, which couldn't be explained by the gibbous in the lower thoracic region.
So are we thinking that there are two pathologies here, with the brain and the spinal cord?
Yes, sir.
Yeah, but structurally, I think it could be a craniospinal pathology. The spinal cord atrophy is quite strong in this case, I think. And you wonder if the signal is also increased in the cervical cord from what you're showing.
Yeah. So I'm just thinking if there's a prior history of myelitis or myelopathy, and these are just chronic changes in the cord that thinned out.
But you don't have a history, do you?
Yeah, we don't have an history. Oh.
Yale is trying to say something.
No, I'm just saying, I mean, it doesn't, because you would know better than me. This to me doesn't look like myelitis. It's just a central cord, no? The spinal cord. What do you think the abnormality in the spinal cord?
Yeah, I just think it's an overall volume loss of the cord, and it's the same thing that's going on in the brain. Can't put it together. I can't give a genetic answer.
The only one thing I thought, the combination of the frontal bossing and the peripheral is some of these pig C and pig, although the pigopathy sometimes can look a bit like this. I have two patients, I think they have pig T or something, that they have the frontal bossing, and they can sometimes get peripheral nerve involvement. But I mean, I don't know, are we trying to narrow down the genetics, so is the next stage would just be to go for whole genome sequencing?
Pawan, what's the follow-up?
What's the next diagnostic test? Are we trying to narrow down the panel, or?
Yeah, we are considering the genetic test only.
Yeah. And how big is the head circumference? Is it way off this? What's the head circumference part of the microcephaly? Is it, what centile is it?
Just about 97 centile.
Okay.
Okay. So if we get a gene, we'll come back with the diagnosis. Thank you. Case 2, Pawan?
Yeah, I am there, sir.
Okay, Geeta, yeah.
Yeah, this girl is a 15-year-old female child, normal development, no perinatal issues, and she had on and off headaches initially, and then these headaches were almost for 2 months, and suddenly one day she has complained of a blurring vision, and there was a homonymous hemianopia was there, and following that also she had speech abnormalities, confused, but she was preserved consciousness was there. She was not able to move her limbs that time, and this all lasted for about 10 to 15 minutes. Later on, this dysarthria and motor difficulties have subsided gradually within 10-15 minutes, but her vision issues persisted almost for 5 to 8 days, sir. And when she came to us after 3 months of this event, and presently she has no vision issues or motor difficulties. So she was initially treated in the lines of some inflammatory but demyelinating disorders at Singapore. So that time there were many investigations which were done, like a CSF analysis, CSF glycine, and autoimmune panel, CSF for various PCR studies. They are all negative except for oligoclonal bodies, like they were borderline positive. MOG was negative, meningitis encephalitis panel, it was negative, and also CSF amino acids levels, plasma amino acids were normal. ANA panel was negative, ASF titers were negative. Like many investigations were done. and she was treated in the line. So she was treated with antibiotics and IV steroids, and later on the oral steroids. So clinically, we were like, based on the signs and symptoms, we were suspecting a hemiplegic migraine. So we want to know the differentials for those MRI abnormalities. Like, looking at that MRI abnormalities, do we need to think in the lines of inflammatory or demyelinating etiologies, and what are the investigations we should go ahead?
Okay, right. Thanks, Sita. We have two sets of images. The first set is in April 2022. On top of the T2 axis sequences, there is some degree of volume loss in the supratemporal brain parenchyma, but no focal abnormality is appreciated on the T2 sequences. Posterior fossa, again, no signal changes and the volume is normal. But when you come to the flare signals in the left parieto-occipital region, there is some sulcal and cortical hyperintensities involving the left parieto-occipital region, as outlined in the box. Diffusion weighted sequences, there was, if you see, there is some asymmetrical signal changes in the left parieto-occipital region. Again, it is slightly bright as compared to the contralateral side. These correspond to low signal on the ADCs, don't have the ADC sequences, but there is some restrictive diffusion with some sulcal and cortical hyperintensities in the left parieto-occipital region. Post-contrast study, again, there is some leptomeningeal enhancement in comparison to the contralateral side. You can appreciate that there is some degree of enhancement in the affected area. Sagittal images, this is the affected side and this is the contralateral side. As you can appreciate the difference in the leptomeningeal enhancement. Coronals again depict the enhancement pattern. On the SWI sequences, there was some paucity of the cortical vessels in the affected regions. MRA did not demonstrate any stenosis or abnormalities of the intracranial arteries. The orbits of the optic nerves did not demonstrate any enhancement pattern. So once this scan was done, the labs was sent over and everything came out negative except the oligocoronal glands. The child had a follow-up study 2 days back. And on the follow-ups, you can appreciate that the diffusion changes have almost normalized. No flare abnormalities, though there is some progression in the volume loss that can be secondary to the steroids given to the child. But again, if you see, there's no signal changes. The flare signals which are seen in the prior study have resolved. P2s, again, there is some degree of progression in the volume loss, but other than that, there is no signal abnormality. So based on the imaging findings, we thought of a possibility of flames as one of the imaging differentials that stands for the anti-MOG associated encephalitis with seizures, but the MOG came out negative for this child. Again, the imaging presentation can be similar to flames, which was seen in our case. Hemiplegic migraine can also present with the leptomeningeal enhancement pattern and the focal segmental abnormalities. Though in hemiplegic migraine, the SWI on the affected side is usually more prominent. The vessels are more prominent on the affected side. Infections were ruled out, but that was a initial possibility. And extralimbic encephalitis, most of the antibodies came out to be negative. So at this point, I'll open the case for further discussion by the panelists.
I would definitely put MELAS here as a very strong possibility.
Can I ask you a few questions? Oh.
Yeah.
I mean, first of all, because there was blurry vision, so was it a definite optic neuritis? So how did we shift from optic neuritis to autoimmune encephalitis? The blurred vision was secondary to a field defect, and the fundi looked normal or not?
The fundi were normal. There was no optic neuritis component, ma'am.
Okay, so the blurred vision was only because of the field defect that was thought to be because of the cortical.
Yes, there was only field defects, yeah.
And how, I mean, what do you mean by borderline oligoclonal bands? Were they, what type were they? Were they serum and CSF identical, matched, or were the serum CSF more in the CSF, or just in the CSF but very few? What made them borderline?
They didn't mention anything about that, but they just mentioned as a borderline, ma'am.
Okay, but did they tell you what type it was? Because that's actually sometimes quite useful when you look at the different inflammatory conditions. So for example, if it's type 3 and it's systemic, it would point more to things like, not very much in children, but in adult would be sarcoid. And if we see bands in MOG, it seems to be more type 3, so it's systemic. If they're matched and borderline because they just visibly look weak, then it just tells you that the blood-brain barrier is open, which you can see on the imaging also. So I think before we overcall the abnormal results, it would be good to know exactly what they meant. I agree that the clinical picture and imaging are in keeping with some of these cortical MOGs, and generally the outcome of this group is quite good, and they're very responsive to steroid. The last one I saw a week ago, literally within 24 hours after 3 weeks of spike in temperature and headaches, within 24 hours of methyl pred was totally back to normal. So they seem to be quite steroid responsive, and the thought is that they're slightly less likely to relapse, although I don't think we have the numbers. The only question is that can we be missing anything else? And I mean, I think infection is definitely on the differential. And the other thing is, how many cells were there in the CSF?
25 cells.
Okay, and the protein?
Protein was around 100.
Okay, because very rarely, I mean, I'm just going down the different. If the patient is done very well following the steroids, how much steroids was he given?
30 mg per kg was given.
And then wean or just 5 days?
It was given for only 3 days, ma'am. The main question here, such a transient event and with not an atypical features and complete resolution, single point event, do we need to consider the inflammatory but demyelinating disorders with such borderline reports?
Well, I mean, I think as you go down the differential, the natural history of this with the probable response to steroids would suggest that this is most likely to be an acquired condition. I would have thought that if it's with some of the differentials like viruses or mitochondrial, you would expect, not always, but the recovery to be less severe. With respect to the antibody positive, I mean, in a way, you're treating all of them acutely pretty similarly. This doesn't look like, you know, MS or anything like this that, you know, require monitoring or significant monitoring outside of the relapses. But I have seen a number of, first of all, it may be worth checking that the MOG, sometimes people send it in the CSF, the sensitivity of serum is much higher. So just check that the right sample was sent. And also there's been a number of children that I don't know why, but if you send the MOG very early on, it's negative, then I repeat that it's positive. I don't think it's just an assay thing. It may be that sometimes the levels are too low to detect, and when we do it a couple of weeks after, it's positive. So it may be worth repeating the MOG. And the other thing I do with these patients, and this is mainly because they can sometimes have a radiological lag. So after a few referrals of patients that presented a bit like this, and then a follow-up scan at 3 months was much worse, query new lesion, I've started now doing new baseline MRI for these patients at about, you know, 6 weeks, 2 months after the original event, just because quite a lot of the time you see radiological lag exactly in these type of patients. So you want to know when one event starts and one event finish. But a part of that, I don't think you need to overlabel this. This is, you know, there was some CNS inflammation. I agree that the phenotype is probably most in keeping with a cortical MOG with the absence of the antibody, which could be either because it's a seronegative or because it's, you know, the test wasn't sensitive enough. But the management, he doesn't require long-term follow-up. And he probably requires some form of surveillance and stuff. And I think sometimes with these patients, if you see that they get cognitive deterioration with a lot of headaches and stuff, sometimes, you know, push you to do a scan. And a few times I've seen it with a lot of lesions. So just, you know, have keep in mind that there may be something more chronic, with the caveat that actually this one is probably out of all the MOG patients do the best. Does that make some sense? Or?
Yes, it does. Yeah, thank you. Thank you. Just the question was, when do we need to get a repeat scan done? We were thinking of sometime in November, December.
So I would do one quick, I would do it quickly for a new baseline. And I even tell the parents that I prepare them in advance. A lot of the time it's worse. And it's not because the child is getting better. It's just that we didn't scan them at the worst. So because otherwise you get into trouble.
Yeah, so this was in April. The changes were in April, and we did a follow-up in June. And in June, we did not have any recurrence. So
exactly. So then you can do one more scan and then leave it. If there's no lesion, then I wouldn't scan
Yeah.
outside of a relapse.
Okay. Okay. So only if there's a clinical relapse, we need to scan the child.
Yeah, yeah.
All right. Okay.
And I think this is, I mean, again, Kish would know more, but for migraines and even mitochondrial, that leptomeningeal enhancement would pretty much go against a diagnosis of migraine.
I don't think it does, because acutely you do get it, sort of luxury perfusion with contrast enhancement. So I won't rule mitochondrial out completely. And it won't do any harm. It won't do any harm doing a MR spectroscopy and MELAS testing, which is so cheap.
Of course. Yeah,
because
agree.
it's so typical of MELAS. This
and
MRI
the
finding
CSF protein.
and CSF protein. So I had a patient who acutely had few cells and not protein as high as 100, but just till 50, and had a luxury perfusion, which caused the high protein. And once we did the MRI again, there was no atrophy, but we did MELAS because of these findings, and it was positive.
I take my comment back, because you're right.
Yeah, MELAS has to be ruled out.
Yeah, yeah.
Okay, right. Thank you. Thank you very much. We'll move on to our next case. Pawan?
Yes. This is a 9-month-old child, third born. The other two children are fine, and born to third-degree consanguineous marriage, and developmentally normal, presented with dull activity and acute regression of motor milestone following a febrile illness. Child presently unable to hold neck, and on examination there is hypotonia in all four limbs, and DTRs are quite brisk, and cognitively child looks normal, except for increased drowsiness. And we have advised for MRI brain for the child in view of significant motor regression. There is a significant motor regression, possible white matter disease, which could be a demyelinating or some leukoencephalitis kind of thing.
Okay, right. Thank you. So we have external images. Slight apologies for the images, but yeah, on top we have the diffusion weighted scans, and in the DBWS sequences we have extensive areas of restricted diffusion. If you observe the pattern, it is predominantly in the subcortical regions, periventricular regions, the central white matter, and also along the central tegmental tracts. The deep white matter is relatively spared of the restricted diffusion. On the T2 weighted sequences, we have this diffuse homogeneous involvement abnormality of the bilateral cerebral white matter. The central white matter also demonstrates these hyperintense signal changes. Cerebellar white matter also is abnormally high on T2. And on the sagittal images in the corpus callosum, if you appreciate the pattern, the inner blade of the corpus callosum and the middle blade is more predominantly involved in comparison to the outer blade. Again, T1 weighted sequences, there is some reversal of the T2 hyperintense changes. There's T2, T1 hypointensities in the involved areas. On the flare signals, some refractory change in the subcortical regions, possibly also in the affected white matter, but the image quality is not optimal. So predominantly a white matter disorder with some refractory changes and extensive areas of restricted diffusion, predominantly involving the subcortical and the central white matter. Based on the imaging findings, I would think of vanishing white matter as one of the prime differentials. They can present with extensive white matter involvement, and this diffusion pattern is pretty similar to our case, whereas the areas with high energy or the areas which are spared of the refractory changes demonstrate restricted diffusion, and the areas of cystic degeneration or retraction do not demonstrate restricted diffusion. Central white matter again demonstrates restricted diffusion, and there can be refractory changes on the flare sequences. Corpus callosum can be a clue. The inner blade is more commonly involved in vanishing white matter disorder in comparison to the middle blade in mitochondrial disorders. And this is our case, a zoomed in image of our case. You see the inner blade is more commonly involved, but also the middle blade is also involved. But there's an inner to outer predominance gradient. Based on the diffusion pattern, I also thought of homocysteinurias as a possibility, but if you see the restricted diffusion in homocysteinurias, it is pretty uniform and there is no sparing of the deep white matter. But the white matter changes can be seen in homocysteinurias. There can also be a gray matter involvement. MLC is another differential based only on the T2 signal changes, T2 and phase signal changes. They do not really present with these diffusion changes, and the child is also not macrocephalic. So these are the differences which we thought, and I'll open the case for further differentials, for further discussion. Sorry.
We sent homocysteine, sir, and it was normal.
Okay.
Was there any nystagmus?
No, sir, no nystagmus.
I mean, it is a leukoencephalopathy, isn't it? The question is whether there's a clue as to what leukoencephalopathy it is. So,
Yes.
Biju, why did you ask for nystagmus? Was there something in your mind?
I don't know. I was just thinking of Pelizaeus musbach, but no. Yeah.
But this is not hypomyelination, is it?
Yeah, that's true. Yeah.
Just a comment. We recently, and I don't know if Kish can share the two cases I'm talking about. We had a number of cases of MOG in very young patients that nearly looked congenital or like mitochondrial or leukodystrophy like. And I just kind of, the caveat is that in those very young children with the unmyelinated brain, it looks much worse than what it is. And both patients responded very well to immunotherapy. So it may be just worth doing it just because of the treatability of this. I agree that in this story with the consanguineous family, actually one of my patients also had consanguineous family, but it may be worth just considering it.
One more thing, sorry.
Sorry, Vivek, carry on.
Yeah. So especially with the pontine, that tegmental tract, correct me if I'm wrong, diffusion restriction with this image, MAT1 and 3 deficiency has to be strongly considered. I know that homocysteine is normal once. There's no harm in repeating it because often if you do it a bit late, it can normalize. So, and blood methionine levels should also be done, serum methionine.
Sure. Will do. So, sorry, I didn't get the for the MOG. What was the youngest stage, and do they have that extensive restricted diffusion and so symmetrical? Was the question.
They sometimes, because it's so diffuse, it looks symmetrical. The youngest we had was a 7-month-old, and then we saw a couple of weeks ago a 10-month-old that looked definitely like a mitochondrial leukodystrophy, but the MOG was positive. There was a bit of asymmetry. We plexed her, and she's done very well. So I think sometime in the very young one, because the first one we had, I was convinced it's not MOG, it was actually that suggested it. So I kind of got it wrong because I think in the young one, the scan looks much more worse than the child. The child is kind of terrific.
Absolutely.
The child
Scan
is
looks
not that
much
bad.
more worse.
And
child is very active. Child is very active, alert, and very hypotonic and floppy. So there is a dissociation.
Sometimes with these one, it's either a combination of one. If they've been subacute for a while, and in this age group, it's a bit difficult to see because they don't fall off their feet; they're just not quite right. One of them, there was nearly a month of a subacute history, and the scan looked very similar to that. The other one, again, was just very young. So I think the combination of young age and subacute onset give you this leukodystrophy like, and it's an easy thing to exclude. Sometime if they have a bit of cells in the CSF or if there's a bit of contrast enhancement, it can point towards that, but it doesn't always have to do that. But the fact that developmentally the child was completely normal before, I think just could raise that possibility and worth testing.
Yeah, he was developmentally completely normal. Just 4 days history of loss of head control and floppiness, loss of motor milestones, hyperacute onset.
So 4 weeks of history prior to the MRI would make the MRI much more diffused looking.
No, this is 4 days. 4 days, sorry.
Oh, 4 days. Okay. So maybe just the age. But I think if it's you can have access to the test, it's worth doing.
Sorry.
Look, she's mentioning if you have access to the test, it's worth doing, which we have.
Yeah, absolutely. We'll get it done, and thank you.
And Lokesh, the history is very vanishing white matter-like, isn't it? This acute downfall.
Very yeah. So the age and the consanguinity and the pattern, symmetry and other things with restricted so extensive. But I think worth just once check it. Yeah. Thank you.
Right. Thank you. Next is Dr. Vivek.
Yeah, thanks. So this is a really unfortunate story. 4-month-old baby, eighth child. 4 babies have already died. So 2 males and 2 females. 4 are surviving. 3 are surviving, but all are females. So as you know, the family is still looking for a male hire. So, and you know, all males have died and 2 females have. And this boy is the boy. And he hasn't had any history. This history is of all the 4 siblings, same phenomenology. They will have developmental delay, frequent tonic seizures from 2 to 3 months age, and they will unfortunately die by not more than 8 months age. This child, they just brought for a checkup that he's 4 months old, and because we have had this bad history, you just want him to get checked out. He doesn't have any problem for them, but just wanted a neurologist to see. And he didn't have any seizures. He's already 4 months. He just, maybe I thought had mild hypotonia, and maybe, unfortunately, I don't have a video to show you, but there was not much. He had good visual interaction. At 4, he was having neck control. And maybe if there was this bias was not there, I would have maybe just said this is probably a normal child. But then that bias made me think he was probably dyskinetic as well, more than the normal baby movements. So previous children's MRIs, their workup was not available. MRI was not available, and no workup was otherwise done. And his metabolic workup I had done, which was normal, and this MRI was done at the same time. So my differential, is it late onset NKH or ITPA associated DE, which can, like my previous patient, seizures started at 5-month age in ITPA DE. So maybe his seizures are going to start now. That could be what the experts feel about the MRI.
All right. Thank you. So as you pointed out, NKH and ITPA related features on the MRI, central hyperintensities involving the perimeral tracts, the posterior limb capsules, subthalamic nuclei, and the perimeral tracts in the brainstem. They all demonstrate restricted diffusion with low signals on the ADC sequences. No significant abnormalities on the T2s, but the prime features are on the diffusion and ADC sequences. The corpus callosum is relatively normal for a 5-month child. The brainstem is also normal, and the posterior fossa structure is also normal for the age group. Spectroscopy, I'm not aware of the TEs used, but I think because given the lactate is slightly inverted, this is an intermediate TE. And as you can appreciate, this is a minostrol peak, and it is not elevated at any of the voxels in the bilateral central white matters and also in the frontal white matter. So the spectroscopy is pretty non-diagnostic. There is no glycine peak. So given the imaging differentials, our first differential was thought of ITPA encephalopathy, as Dr. Vivek has pointed out. Also, Dr. Vivek, as group has published a recent paper of 2 cases, and one of the case had a high CSF glycine. Going through the literature, we found that cerebral glycine can be seen in these conditions, whether to include ITPA or not, because the child was seizing, and we did not have, this case did not have a follow-up evaluation of the glycine levels. Other differentials only based on the imaging findings are listed over here. Mitochondrial tRNA disorders, NKH, hyponatremia can also present, and other possibilities such as the PIGA deficiency. Pigabatrin is not relevant in this case. CLCN2 is more in other age group, and MCUD is also, the imaging pattern is not typical what we've seen in our case. So these are the differentials, and ITPA is the working diagnosis, at least on the imaging findings. Dr. Vivek, do you want to elaborate on the paper you have published with the glycine levels? Could be a mimic of NKH.
Yeah, so of the 2 patients, one had high CSF glycine. That baby had presented with history of being sort of encephalopathic from neonatal period, but having his first seizures from 4-month age and very frequent seizures with burst suppression, so a DE. And I just thought it is NKH, especially with the history of being encephalopathic, but no seizures before that. And we did his CSF, and his CSF glycine was really high as compared to blood, and we just thought we have the diagnosis. But when the genetics came, it was ITPA DE. And as we know, the similar MRI changes makes one wonder that in these situations, secondary glycine elevation causes the MRI changes.
The case is open for further comments if anyone want to.
I mean, other than ITPA and NKH, what else would be such devastating metabolic encephalopathy? So I think
Clinically or imaging wise, because imaging wise, I think these are most of the differentials.
I think it's still very likely to be ITPA. Yeah.
Yeah. Is the child microcephalic, Dr. A? Or is
No,
it too early
normal
to
head
define?
size. Normal head size though for age. He looks like a normal child.
Okay.
Just my bias of hypotonia and mild dyskinesia. And no encephalopathy. So, but though late onset NKH can, but they normally late onset NKH have thin corpus callosum, I think, with some colpocephaly. It's only the bad ones who present in the early neonatal period who present like ITPA. Is that right, Nihaal?
Yeah, that's right. And no elevated alkaline phosphatase, just to rule out the bigger deficiency, which has similar imaging pattern, but
no, not done it. I'll do it.
yeah.
Not done. Thanks. Thanks.
All right, thank you. Next case is from Dr. Jubi. Dr. Jubi or Dr. Pooja want to present, please?
Yeah, I'll be presenting. So
Yeah.
he is an 8-year-old boy whose parents came to us because they want to plan the next child, and they came to us for a genetic counseling. So this boy, he was a normal delivered term baby, 3.5 kg, no adverse events, no NICU admission, but always had delayed milestones. And at 8 years, he can walk with support. Although he was gradually gaining milestones, never a regression, but a significant delay. On examination, the head size was 49 centimeters, which is -2 to -3 standard deviation. There are coarse facial features, broad nasal bridge, thick lip, periorbital puffiness. So he has a dysmorphism. The tone is a little low with brisk reflexes, so looks like central hypotonia with some amount of gait ataxia, although other cerebellar signs were not there. So yeah, so I just had two things in mind. One was, as you would tell, Nihaal, that GPs are T1 hyperintense, but I could not get T2 hypointensity, so it was difficult to fit into FUCO. And another thing I wanted to ask if hypermagnesemia should also be ruled out.
Okay. All right. Thank you. So moving on to the images, the age again, Dr. Julia, I forgot. 8-year-old. Okay. So for an 8-year-old child, there is a hypomyelinating pattern in the supratemporal brain. As you have commented on upon, the global pallidi are not hypo. There's no signal abnormality in the global pallidi. It is not hypointense. Telomere appear to be slightly reduced in volume, but not very significant. Again, there is some pontine abnormalities in the form of T2 hyperintensities. The cerebellum demonstrates atrophic changes. This is a T1 flare. So on the T1 flare also, you can appreciate the white matter abnormalities, some hyperintensity of the global pallidi, pontine hyperintensities, and on the sagittal images, you can appreciate the hypoplastic and atrophic vermis. The corpus callosum also reduced in volume. No abnormalities on the SWS, no abnormal mineralization for the age. This was a T1 MP range sequence. We did not have an axial. This only we have sagittal and coronal sequences. And on the sagittal images, you can appreciate the T1 hyperintensities involving the global pallidi subthalamic nuclei going up to the dorsal midbrain. The coronal images better depict the hyperintensities of the deep brain nuclei and the brainstem. You can also appreciate that there is atrophy of the cerebellum with some hypoplastic features. So the only thing was it does not correspond with the T2 hypointensity, the T1 hypointensity. There's no abnormal mineralization. The difference was what we thought if we go along a pattern recognition approach. If you have a cerebellar atrophy with hypomyelination, these are the various differentials which need to be thought of. The brainstem abnormalities in a hypomyelinating disorder, Pelizaeus-Merzbacher, 4H leukodystrophies, they have all peculiar abnormalities of the brainstem. Fucosidosis as what was differential, It usually has T1 hyperintensities, but they have usually corresponding T2 hypointensities and associated with hypomyelination. They can be associated with these clinical features. Hypermagnesemia is raised. They present with T1 hyperintensities, but with corresponding T2 hypointensities, and the white matter is not hypomyelinated in a hypermagnesemia related disorder. So that is a atypical finding if you're considering hypermagnesemia. The less likely differential one would think of given the T1 hyperintensity is an NBIA, but again, there's no abnormal mineralization on the SWI sequences. So these are our differentials, and I'll open the case for the experts to comment upon.
Okay, thank you. So his teeth are normal, and there are no roving eye movements. His development is pretty good for typical PMDs. And another thing, I think we can see GP interna and externa separately. So will that be a point in favor of FUCO?
Nihaal, I think the T2 is not normal on the initial scan, but that's me looking at it with a very bad hay fever out here. So that if you look at the globus pallidus, it's a bit swollen on both sides.
Yeah, it is swollen. You can better appreciate that on the FAIR images.
And also, thalamus is indeed a bit small and dark compared to what's going on around it. So what's keeping it away from fucosidosis?
Just that there's the signals on T2 are not there, and I think clinically it does not have
be a phenomenon, right? It's not normal on T2, right? I mean, what we are seeing, it's not normal. So that at least there are T2 and T1 changes, and I think what will become dark later starts with a bit of swelling like this.
Okay.
Just clinically to add, there's no organomegaly, right, for the child? Was it too early to present?
No, so we checked for organomegaly and peripheral neuropathy, which is there in fucosidosis. So there is neither. But this input by Dr. Kesh will be helpful for us if these can be the early changes in T2.
And we would say yes to that.
Yeah.
Right.
Okay. So are we sending it for genetics, Dr. G?
Yes, absolutely. So that's the purpose they have come to us for. So I'll update about the genetic report.
Oh, all right. Okay. Thank you.
Thank you.
Next case is from Romit.
Yes, sir. So this child presented to us at 1 month and 10 days of age with history of fever, few episodes of vomitings, and seizures. So the child was managed as a case of meningitis and then referred to us because of refractory seizures. On admission, the child had high 9-gap metabolic acidosis and had persistent hyperglycemia, so above 400s, and a partial response to insulin therapy to the hyperglycemia. And because the urine ketones were also positive, the child had some like neonatal diabetic ketoacidosis type of presentation. So we thought of genetic causes, very early onset refractory hyperglycemia. And A1C done, although it is not representative in neonatal because HbF is the main hemoglobin, but the raised values do have significance. And we also got fructosamine levels, which is an alternative method for. So it's been a long-standing hypoglycemia, even for a 1 month, 10 days old child. And the whole exome sequencing was sent US in the KCNJ11 gene. So we were clinically thinking of Dent syndrome and had KCNJ, but the MRI changes were something I could not see in the review of literature, the GP signals especially. So that was a doubt, whether other etiologies or are we missing something, or these changes have been described, I don't know.
CSF, lactate, blood lactate, anything? TMS, organic aciduria?
We didn't do we didn't do because the only thing, the CSF analysis was done, that was normal.
Okay.
But we didn't do the
We'll
metabolic work.
All right. Okay. We'll move on to the images. Again, slight apologies for the quality of the images, but on top we have the diffusion weighted sequences. There are some areas of high signal changes in the bilateral symptom semi-oval and superficial white matter, also involved in the bilateral global pallidi. I'm not sure if the corpus callosum and the rest of the white matter is also abnormal on the diffusion. I don't have an ADC sequence. There are also patchy areas of involved in the cerebellar white matter on both sides, right more than the left. T2 again, slightly distorted image, but some edematous changes I'm not able to make out if this is artifactual or real. Again, the hyperintensities of the cerebellum can be appreciated. The brainstem also demonstrates these abnormal signal changes. Corpus callosum is, for a 2-month, is probably slightly thin, but I wouldn't comment on that. So these are the images which we have. So in the review of literature for the Dense syndrome, they have mentioned the scans are usually normal or there is some degree of atrophy with white matter lesions. Again, very non-specific imaging findings. I was thinking on the imaging to at least rule out mitochondrial disorders as a differential. And if you focus on the globus pallidus, these are the differentials for the global pallidi changes. So at this moment, I'll open the case for further discussion.
How do you tie in the hyperglycemia with any of this?
With the imaging findings?
Yeah, or even.
Yeah, I checked for hyperglycemia. They usually have striatal abnormalities. Asymmetrical can be unilateral, but yeah, striatal hyperintensities can be seen with some white matter abnormalities. So for hyperglycemia, those are the imaging findings which I could find.
No, the question was more
Nihaal,
about.
that will be for an older child, right? At 2-month age, how will you know that this?
Clearly, the hyperglycemia is masking or unmasking a metabolic problem which is driving it, right? I just wanted to know what would be the clinical angle in terms of explaining the acute changes of MR. Can't just be a mitochondrial disorder, can it? Unless one of those gives you hyperglycemia.
But the clinical phenotype is exactly matching into the KCNJ11 mutation because the child still is on sulfonylurea to control the hyperglycemia. So the child still requires that it's 1 month after that. So at 2.5 months, the child is still hyperglycemic, requiring sulfonylurea to bring down the sugar levels. So the clinical phenotype is definitely matching. The only thing is there's a difference between the radiology and the clinical phenotype.
No, Romit, it's not the difference. You have picked up the world's first case of hyperglycemia-induced damage at 2 months. That's what it is.
I don't know whether there was a second insult because there was a fever, vomitings, although there was no electrolyte disturbance, as we see with hyperglycemia, a lot of these children will have hypernatremia, but the sodium levels were normal.
It's too symmetrical, right? So it has to be a systemic metabolic cause. So it's possible that hyperglycemia at 2-month age causes this because nobody knows. And myelination is not complete.
Yeah, but what about the KCNJ genetic discovery? That might be relevant, isn't it?
This is seen with the neonatal onset diabetes.
Is there a link with hyperglycemia and the mutation?
What was the mutation causing the Dense syndrome?
What was the insulin levels? Insulin levels were high.
So the insulin levels were low. C-peptide and insulin levels were low.
So yeah. So if it is poor response to insulin, then it should be hyperinsulinic, isn't it? Hyperglycemia. Insulin level should
see there. So KCNJ11 causes both neonatal diabetes as well as refractory hypoglycemia. So the gain of function mutation causes refractory hyperglycemia. The loss of function mutations in these ATP sensitive potassium channels, they cause diabetes. So and it's very specific. sulfonylurea, the glibenclamide that we started for this child, is actually the girl is showing a very good response. So for most of the other neonatal hyperglycemias, sulfonylureas don't work.
Mhm.
And why is it a VUS? Is it because parents have not been tested, or?
I'll have to ask genetic because it was clinically fitting and it was a new mutation, so it was not
Right.
reported.
Right, right.
And Nihaal, from memory, in this dense syndrome, people have described white matter lesions, but they're quite spongiform lesions, like in this case, right? Are these two pictures from the publications that you put here?
Yeah.
Because they could be more spongiform and swollen as well. I mean, these look like very mature at this point, isn't it?
Mm-hmm.
One for checking the published work on this, but I think the MRI is consistent.
Okay.
Sorry. So what's the final verdict?
Then the related features, first case possibly. Roman parents are going to get tested, or is
Yeah,
no further
we have
testing
advised
required?
differential testing, but I'm not expecting because it's an autosomal dominant, so
Okay.
less likely. But yeah, we are getting it tested.
Okay.
And the corpus callosum is also thin, right? For this age.
It's 2 months, so
normal.
it's pretty difficult. It's
Okay.
difficult to test. All right, great. Thanks so much.
Thank you, everyone.
Yeah, next one is from Dr. Vivek.
So this is a age, I think I was writing that, I think it's 9-month-old baby who had global delay with and central hypotonia with significant dyskinesia, choreiform movements, with good visual connect, no dysmorphism, normal, low tone, not high tone, in legs and arms. So legs were not differentially affected, and why I'm stressing on that is because of what comes on in the MRI later. And one of his female siblings has passed at 18 month age suddenly with normal development, no concerns, and family just says slept at night, fed, morning she was no more, and they wondered it was aspiration pneumonia. And for this child, he's always been affected, so he's delayed. So like at 9 months, he's performing like a 5-month-old baby. His basic bloods were normal. Lactate, homocysteine, prolactin I did for maybe, poor man's neurotransmitter in the sense because he was dyskinetic and hypotonic, not for tyrosine hydroxylase deficiency. That was what I was thinking. And then we did this MRI. And there was no neonatal issues. So birth history was normal.
Okay, right. Thanks, Dr. Vivek. So this is a child at 9 months, and you can appreciate that there is a volume loss in the frontal lobes on both sides. Some areas of T2 flare hyperintensity is likely gliosis because of the and prominence of the frontal horns. You can appreciate that there is the frontal lobe volume loss, widening of the subarachnoid spaces. Coming down, posterior fossa appears normal. On the sagittal images, you can appreciate that the corpus callosum is thinned out. More along the anterior aspect, the anterior body is more thinned in comparison to the soil. So overall, a diffusely thinned out corpus callosum with an almost equal gradient. Again, you can appreciate the thinning of the corpus callosum in comparison to the splenium. The anterior part is more thinned out. No mineralization or hemorrhage on the SWI sequences, and no abnormalities on the diffusion weighted sequences. Spectroscopy was done. I cannot appreciate any diagnostic peaks on the spectroscopy. So just to point out a possible PVL mimicker, in this case, this is a typical imaging feature of a white matter injury of prematurity or a PVL, where you have the posterior to anterior gradient of volume loss of the corpus callosum and also these periventricular hyperintensities with squaring and wavy outline of the lateral ventricles. In our case, the white matter was more along the front anterior aspect. The corpus callosum also was thinned out diffusely with a slightly anterior predominance. So thinking of a possible genetic etiology rather than a PVL, cannot point it out to a possible gene or a spectrum, but thinking of a neurodegenerative disorder and likely genetic disorder. At this point, I'll open the case for further comments.
What happens at the ADC Wi-Fi? Do they have their MRIs are fairly normal, aren't they?
I didn't get you. ADC Wi-Fi?
Yeah. I was thinking like the children that we see with Korea and Korea.
Okay, yeah. They have caudate nuclear atrophy.
Yeah.
But I'm not sure of the selective involvement of the frontal lobes. I think the volume loss is because of the frontal lobe volume loss rather than the caudate nuclear atrophy.
Yeah, because initially when I heard that it seemed to fit in with ADC Wi-Fi, but yeah.
Can you go back to the history? Is this a progressive problem in this child, or is it a one-off, something happened?
So I've only seen him once. So at this stage, it's more of a child who is progressing, but slowly. So he's not regressed, he's not plateaued. And at birth, they are certain. There is no history of ICU admission, no events. And the child was good weight. So there was no antenatal nutritional deficiency or any, any event which would, so he was good weight at birth. In fact, after seeing the MRI, I'd counsel them that there must have been some undiagnosed event at birth or before that, before I sent it to Nihaal, and then Nihaal, of course, enlightened me that the corpus callosum involvement is not like a acquired cause. It's more we have to think of genetic causes as well. Because for me, it looked as if there is gliosis, some film event with frontal lobe involvement, and the ventricle has got just ex-vacuum dilatation. But for that, as Nihaal has mentioned, the splenium should be more affected, which here it is not. It's the other way around.
And there wouldn't be selective volume loss of only one lobe, unless it is a watershed injury.
Right. And he's not anemic.
Yeah. So I think probably send for genetics and check, because of the imaging, there's no spastic diaplegia or paraplegia.
No. SPG is a possibility. SPG, is it a possibility with these frontal halves being, or
not the typical year of links, but the other SPG forms can be present.
Okay.
Okay, right. Thank you.
And the movement disorder was typically choreiform and not just a hyperkinesia.
So it is choreiform.
But more was it dyskinetic or choreiform, pure choreiform?
Choreiform. So sorry, I should have written choreiform. Choreiform.
Yeah, please keep us posted on. It would be very interesting to see what the outcome is. Yeah.
Sure.
All right. Thank you. Next two cases from Dr. Rashmi.
Hi, I'm Dr. Rashmi Ediga. I'm at Rainbow Children's Hospital at Bangalore. So this is a 11-month-old baby who, this child was born via IVF, X32 plus 1 weeks, and they were on NICU for 15 days with low birth weight, 1.37 kilos. So they presented to me with global developmental delay, truncal hypotonia, and increased tone in both upper and lower limbs, spasticity at the ankles. The TMS was normal. Actually, I was suspecting some birth-related injury and then asked for an MRI.
So the MRI is at what age, Dr. Rashmi?
Sorry? MRI was done at 11 months only. 11 months only. It was only done last week.
Okay. So we have the T2 axles on the right, and you can appreciate that there is some degree of delayed myelination in the cerebral white matter. The corpus callosum is spared, but you can also appreciate that the bilateral basal ganglia are hyperintense. The anterolateral thalami demonstrate T2 hypointense signal changes. Posterior fossa structures are normal. Corpus callosum possibly slightly thinned out. Brainstem also appears normal, but there is some possibly some degree of volume loss. Nothing on the GRE sequences. Spine was cleaned and the cord appears normal, no focal abnormalities or thinning of the spinal cord. We have only these images. Diffusion and ADC sequences are not available. So based on these pattern of delayed myelination and involvement of the deep gray nuclei with hyperintense basic ganglia and dark thalami, thought of a possibility of a storage disorder such as gangliosidosis, which presents with similar imaging abnormalities. This is a paper from the CMC group, which was presented at the RSNA 2017, which has a pattern recognition approach for the dark thalami. So dark thalami with hyperintensity of the corpus striatum, one must think of the gangliosidosis, which was seen in our case. I think there was also a clinical query of biotin thiamine responsive disorder based on the striatal involvement, but the imaging presentation is slightly different in what we've seen in our case. They can have striatal abnormalities, but there is abnormalities also in the periaqueductal region. There's no dark thalami in the basal ganglia, biotin thiamine basal ganglia disease. The cortex also can demonstrate hyperintense signal changes. So based on the imaging findings, I would think of a lysosomal storage disorder, and I'll open the case for further discussion.
Yeah, I have sent off genetics testing. So
anything on the fundoscopy, organomegaly, skin lesions?
No, there's no organomegaly. I have also sent them for ophthalmology assessment as well.
Okay.
I've sent off ophthalmology assessment and genetic testing.
And the head circumference is normal?
Yeah, head circumference is normal. Head circumference, weight, height, they're all on the same centile.
Okay. Then no comments with. Yeah.
I don't think there's information to pinpoint any diagnosis with the information that we have, I think, because this is a preterm, low birth weight, thalamic hyperintensity. I mean, these are all in the gangliosidosis. Yes, and you can count it in the differential, but I think this is the differential is very wide at the moment. I think it's the right way. The right thing to do was to send off the genetic and also complete the metabolic testing. This could be anything. This is a proper CP mimic, and this could be anything. Yeah.
Yeah, I think they had reported as hypomyelination, Pelizaeus-Metzbacher.
But this is an 11-month-old MRI, isn't it?
So it's just delayed myelination based on the imaging.
Yeah, they had reported it like that. I'll keep you updated the genetic results.
Okay. Okay, right. Thank you.
Thank you.
The next case.
Yeah, this is an interesting boy. So he presented a 15-year-old boy. He had fever for 3 days and he had headache for 3 days, and he just straight away went into altered sensorium, encephalopathy. So he presented to us, and then initially, like, we thought he had encephalitis. So we did CSF analysis, started him on ceftriaxone, vancomycin, acyclovir, and the CSF showed 6 cells, protein and sugar was normal. And following this, we also sent blood and CSF for autoimmune panel and MOG and MSOD, and serum MOG came strongly positive. So following that, we started him on methylprednisolone and IVIG. And methylprednisolone, we went on a gradual reduction regime rather than we gave 5 days and then gradually reduced. So we were told that the MRI has a lot of brainstem changes, which might, explain the fact that he had on the ICU also he had variable blood pressure. He had to be ventilated and all of that. So I just wanted to discuss here.
All right. So here are the flare images on top. Slightly equivocal changes, hyperintense signal changes in the cortex, in the parietal posterior frontal lobes, over here and over here. Coming down to the deep gray nuclei, you can appreciate that there are hyperintense signal changes in the parietal thalami. And the posterior fossa, the brainstem is edematous, and you can appreciate that there is some lesions also in the cerebellar white matter. Again, the abnormalities of the thalamus can be seen on the T2 weighted signals, and the brainstem and cerebellar white matter abnormalities also can be demonstrated here on the T2 signal changes. So that you can better appreciate the signal change abnormalities of the brainstem. Corpus callosum is normal. Contrast images. I could not appreciate any enhancement on the supratentorial lesions. I'm not sure if this is enhancement or just some vessel, but it is not very significant. Optic nerves, possible perineuritis on both sides. If you correlate that with the coronal images. T2, there is no focal lesions of the spinal cord. So
T2, they told us there was conus or something. In the conus, there was a change, they told us, our radiologist.
I would think that is more related to motion.
Motion artifact, is it? Okay.
Yeah.
And the supratentorially, we were told that it was all fine. But thalamic changes explain a lot of his clinical condition. I'll come to it.
Yeah. So as you mentioned, which is MOG positive. So MOG positive related disorders can present with optic neuritis, basic ganglia thalamic involvement, and also the posterior fossa abnormalities. These are again differential imaging phenotypes of the MOG antibody related disorder. Common encephalitis, given if there was only isolated brainstem involvement, is a differential. At this point, I'll open the case for further discussion.
So I think the thalamic changes, we were not, we didn't appreciate it so much. So thanks, Dr. Nihaal. But that would explain a lot because we ventilated him, and after once we remove the sedation, he's not able to move his limbs that much. So that could, I think that would explain that. So 1 week down the line, there is improvement, but there is very partial improvement. So we've also given him rituximab. So we'll have to wait and see how he responds to the treatment.
Can I make a few comments?
Yes, please do.
Yes,
yeah, please.
So first of all, I think that the history with that headache and sleepiness, and that is very typical of MOG. And the thalamic lesions, a lot of the time, I remember us sitting together looking at the first scan, and it's a bit equivocal, and then you see it progressing on the second scan. So it's really important to highlight that with all these patients, the imaging are very dynamic. So we get a lot of patients that are coming from other hospitals and get repeat scans here, and it's nearly always kind of changed over a few days when you're looking for characteristic, including patients that the MRI has been initially normal and then it got very abnormal day 5, for example, or day 7. So, if the child becomes sleepy and you haven't picked up anything on the first scan, it's sometime worth repeating. The second thing with the acute management, I've actually noticed that I actually escalate to plasma exchange more and more because I find that if I do, they do much better. So that would be my kind of first line escalation, particularly if you see signs of either a lot of cells in the CSF or contrast enhancement or anything suspicious of highly enhancing. I would go to Plex. The rituximab, it's now, I've just been in a MOG meeting in Lyon, the European MOG meeting. It doesn't categorically work. We all actually going away from using it because A, it doesn't work, and B, there's been some, particularly in children with relapsing disease, there's been a number of cases. We had 2 a few years ago, or 6-7 years ago, we stopped using it after that had a rebound, quite life-threatening relapses. And if any of you read, there was a multi-center kind of data collection from 120 patients with MOGAD on rituximab, and 79% of the patients who relapsed on rituximab had absent B cells. So if you think that this is a disease that the relapse rate is anyway quite variable, we really don't feel that Ritux works for this condition. So I mean, I don't think, I don't know, it's tricky to know. You had to escalate to something, but in the future, I probably would escalate more to something like plasma exchange in the acute setting. And then we also have quite good data on the use of IVIG that I don't find very good in the acute setting, but regular IVIG for relapse prevention. So I guess sometime if you want to, get the child off the steroids acutely, you may go and say, let's do 3 or 6 months of IVIG so I can get him off the steroids. And that's probably safer than Ritux, and there's no question about the fact that IVIG works much better than Ritux for relapse prevention.
Okay. What about your experience with MMF, mycophenolate?
So I use a lot of MMF, and that's mainly because in the UK, IVIG is very expensive. But what I've started doing over the last year is some of my worst patient, I would say it's definitely less than 10% of the MOG patients I see, the ones that were on IVIG regularly and kind of used to get a bit of symptoms every time just before the infusion. I now do double therapy, MMF and IVIG. And then it also gives me the ability of them space out the IVIG and stop it. I know in India, you guys have, it's much easier for you to give IVIG and it's much cheaper. I don't know if I had total freedom, I would have gone for this combo. I initially went for it because I was worried during COVID that my patient won't be able to come for IVIG and things. So I was like, okay, let's double cover them in case they stop me from admitting them. But actually, I feel that the control is better with this combination treatment. And again, I've mentioned it in the MOG meeting 10 days ago, and quite a few people. So Kim in Korea have started using it. It says you also find that it helps with the control, particularly initially. So if you have really refractory children, sometimes we see them, they have like 3 relapses over the first year. We haven't even managed to figure out what to do, and they keep relapsing. So that's the group really to maybe do combination therapy, MMF and IVIG. I wouldn't necessarily start every child with a second relapse on MMF and IVIG because some even without any treatment.
Yeah. So I just wanted to ask you, how would you assess that, that they are getting better? Obviously, the antibodies are of no use, right? They'll be positive.
I mean, I expect full recovery. I think these patients, after even most severe patients, have made. We had a few, but very, very few, that the vision didn't recover completely. But most of these, to be honest, were very delayed presentation. But generally, I would expect, particularly, with a patient like you presenting, for him to make a full clinical recovery. The MRI doesn't, we're just actually looking at it, and it's something that maybe you guys can also look at, whether you get complete symptom MRI resolution or partial actually predict outcome. And I don't think it does, but we're looking at it now a bit more systematically. But you would expect to have at least for them to be ambulatory and going to school. That's how and if they're not walking, as I said, I escalate to Plex quite quickly. So if I see after the 5 days they're not walking, I go straight to Plex. And with these brain ones, sometimes it's worth to give like 6 weeks of steroids, so a bit longer than you do for the optic neuritis.
Okay. Another thing is, when would you do a repeat MRI? You said that
I would do a repeat MRI as a new baseline at about, we discussed it with the first patient. So somebody like him, you may want to do a new baseline kind of soon after he leaves the hospital. So then if he has new onset of symptoms or he then relapsed when he stopped the steroids, you know if it's new or old.
Okay, fine.
And then after the new baseline, if they don't relapse, I tend to do one extra scan 6 months after. And if they don't relapse, probably MRIs. Sometimes out of curiosity, every couple of years, I just repeat it a bit academically, but it's definitely not anything I would act on. There's been some reports of, asymptomatic lesions. I think a lot of these asymptomatic lesion is exactly what I was talking about before, about this radiological lag after the attack. So you nearly come across as asymptomatic lesion. The other thing is I had experience of a few patients with MOG disease that suddenly had some headaches and went to the local, but really weren't that bad. And they get a scan at the local hospital. The scan is terrible. But if I would have reviewed the patient, I would just said, oh, it's fine. It would get better. And it does get better without me. So I think some of these patients, when they get into current illness, they get this headachy, they're a bit unsteady feeling, and that's kind of mini relapses. And sometimes it reflects a new MRI lesion. So if you're the kind of clinician that's a lot and they tell you about every little thing, then you can attribute these changes to a clinical change. Whereas if it's like a big center that see the cases, once a year and they can't remember what happened to them in November, then you miss those kind of episodes.
And another thing I wanted to ask you about optic neuritis, the MOG, the children who present only with optic neuritis, MOG-related optic neuritis.
Yeah.
How long do you expect them to take to recover their vision? Because I get different things from the ophthalmologist and all that. How long
again, MOG is a disease that generally has very good response to immunosuppression. So I really aim for achieving normal vision, and I escalate. So I actually over the years started treating the acute attacks a bit more. If the vision is abnormal at 5 days, I would do Plex, I would do IVIG. I really think that this is a treatable disease. And I do my best to give them that. I would not then start maintenance immunosuppression with anything, but I think for the acute attack, I do think we need to aim for for full recovery and not a bit of recovery.
Okay.
Sometimes if the vitamin D depleted, this is totally anecdotally and maybe like not right, but I've noticed that you really need to supplement it because they come with like vitamin D of 7 or something, and I've noticed that a few of them, when I supplemented the vitamin D, it helped with the recovery.
Yeah, I have found that they're vitamin B12 deficient as well. Vitamin D and vitamin B12 is very low. So I have given them
the one that don't recover. There's been now a number of patients with MOGAD and the feeling that it was MOGAD, but also has the Leber's mutation. I think there was one with Paul G. So I think you need to be a bit careful with that. But I think the point is that not to exclude, like sometimes we go, oh, you know, they have Leber's, they can't be MOG. You can have both. It's very rare, treatable. I think if you're seeing that the recovery is suboptimal or, you know, they don't recover at all, sometimes it may be worth looking for some of these differentials because they can occur. And I think the other thing is just clinically, and it's really a big tip, and if you'll see from the cases we discussed today, the headaches is a really key feature. If I see an optic neuritis and they have no headaches, it's very unlikely to be MOG. So if you see those MOG patients, normally they have blurred vision, then the headache, initially they have like pain on eye movement, then a really bad headache. And the headachy feeling is a very MOG-like. You don't see it with MS and you don't see it with ACU.4. So just a clinical clue.
And just last question, sorry. How long will they take to make a full recovery?
Some of them very quickly. I think I don't think we know, and I think that's the kind of the most important thing to find out. Whether the recovery is individual, like whether you have some patients who recover better versus one that recover not so good, and in a way I think the next step with, you know, precision medicine in this disease, and this is maybe why we haven't figured it out, is that the response to treatment and the recovery is very different, and there is an age related, there may be sex related, there may be racial, you know, tendency, but I think this is what we don't know. And sometimes even with the relapsing patients, you have patients with optic neuritis that you give them one dose of steroids and the vision is totally normal, and you go, okay, if they have one optic neuritis a year, they respond totally to steroids, should I start them on MMF? And I don't always do that, because I think if they respond so quickly, then you don't want to immunosuppress them. So I don't think those protocols are very easy to follow, because I find that every patient I have a slightly different angle on. But these kind of webinars I think are quite good to discuss these patients. So I will try to come, and you can always email me.
Yeah, that's very, very helpful. Thank you so much. And thank you, Dr. Nihaal, for including this at the last minute.
No problem. Thank you. Thank you.
Hi, Dr. Jael. This is Dr. Kavita Srivastava. Good evening, everyone. Can I ask a question related to the same? Yeah. So, how do we define the criteria for relapse? Like if they are coming with some neurological symptoms, but there is no new demyelination on the MRI, do we still call it relapse, because the antibodies may persist for years together? So,
yeah,
example,
so I think it's very interesting. Every time there's like an NMO meeting, they spend like 2 hours defining relapse. I'm a bit more pragmatic, I think, with those things. I think it's depends. Sometimes you get these patients, you know, they may have had a previous optic neuritis. It's a hot day, or they have exam, or they're stressed, and suddenly the vision is a bit blurry. I think unless you get a new neurological signs in association with new MRI abnormalities, I wouldn't call it relapse. I probably would undercall relapses than overcall them.
Okay, thank you so much. Because
so unless you have a clean neurology in association with new MRI lesions, or you know, optic neuritis, if you get any kind of I think you need to get objective evidence. It becomes a bit tricky in that one really bad group that I was mentioning earlier, with a kind of leukodystrophy like MRI, because sometimes if they have like a bit of ataxia or kind of this spastic ataxia and they're totally fine, over time you may see a bit of symptom progression, or some of the children that may have a bit of a hemi, suddenly the hemi is a bit more. And I think we really need to, in the group that the clinical examination is abnormal and have some motor and some ataxia, they may have disease progression without relapses. Also, some of the children that may have had one eye that is, particularly in adults, that the vision is not so good, they may also get worsening of OCT or worsening of even visual acuity without relapse. And that group probably doesn't respond to immunosuppression. And we don't really see it with aquapoint 4. So we would see it with MOG with a very kind of heavy lesion load or, abnormalities that seem to go over time, like nearly progressive. But we don't see it with aquapoint 4, and we think that this disease progression doesn't respond to immunosuppression.
Thank you very much. So have you seen patients who are just, like this, one of our patient, she had optic neuritis, and now she has just come with status epilepticus, almost refractory, and she was having, in fact, stimulus-induced seizures. So whenever she was chewing on the right side or brushing, she used to get a, focal into generalized seizures. And that was like going on for 2-3 days, and we needed actually escalation to up to midazolam drip. But there was no new lesion on the MRI. And the titers
so
of the
she probably had the cortical. So sometime if you do, Kish would know better than me, but I think you can, these patients, we've seen a few of them that had normal scan at a different hospital, but then they do this post-contrasted flare that can really pick up the signal change in the, so sometimes you can see that. And I doubt this is totally unrelated to the MOG. Some of them we get abnormality. Also, if you look at the Barcelona data, they had many patients with, so MOG is now thought to be the second most common autoantibody in autoimmune encephalitis after NMDAR. I personally don't see any of the other one, the LGR1 CASP. I don't really see them. I see aquapoint 4 and I see MOG. So you can actually get, and I have 2 or 3 of these patients, MRI negative autoimmune encephalitis with MOG antibody. So maybe my suggestion is try to use either steroids on, I would start steroids instead of Midaz, no? But we can chat separately if you want to go through all the case. But I would maybe go down the immunotherapy, maybe worth repeating the CSF and just look at the cells and the bands, because that sometimes tells you, for example, if the Q albumin is high, you may choose to go for Plex because the blood-brain barrier is open. You have all those like tricks. Sometimes some of these patients have very high CSF IL-6. I haven't used tocilizumab. I know there's a few trials starting, but it may be interesting to see which group would respond. So there are some biomarkers that may be helpful when deciding on treatment.
Okay,
but
okay. I think that's a good idea.
And maybe worth repeating the imaging and also treating with immunosuppression.
Sure. Thank you so much. Thanks.
Yeah, in terms of the comment about flare contrast, I'm telling everyone to basically, if they're giving contrast, to repeat a flare or at least just do the post-contrast flare. You don't lose the benefit of the pre-contrast if you drop it altogether, but you get a lot more added value if you can do the flare at the end of the whole thing.
Okay, great. Thank you. Thanks, everyone.
Thank you so much. It was an excellent discussion. Thank you very much.
Moving on to our second last case is from Dr. Divyani. Dr. Divyani, further you can present the case.
Yeah, hi. Can you hear me?
Yeah, please go ahead.
Okay, wonderful. So this is a patient who is still admitted with us. She's quite sick actually, so I just thought we'd bring it here. This is a 14-year-old girl. She presented with a history of 1 episode of focal seizure, which with generalization, which was in March 2021. And this was followed by a history of multiple falls and loss of consciousness occurring over a period of 2 months. No real records are available for this particular event, and a medical consultation was done and probably anti-seizure medications were initiated. And with this, the patient became free of her loss of consciousness episodes and falls and became completely independent for ADLs, was back to school and did not have any other issues. Now, 1 year later, that is in mid-March 2022, she developed high-grade fever up to 102 and 103 degree Fahrenheit, which was not really associated with clear localizing features. The fever would respond to antipyretics for a few hours and then recur. And around 5 to 6 days later, she developed multiple episodes of seizures. These were occurring nearly daily and several episodes. And this went on up to early April 2022, finally, when she developed altered sensorium. And by with around 1 week into this particular event, she became mute, incontinent, and developed oromandibular automatisms as per history, and finally was admitted at an outside hospital. After admission, this is the documentation of her examination findings. So she had a poor GCS with E2V1M3. Pupils were normal size and reactive to light, and tone was found to be increased in all 4 limbs with brisk reflexes. Nothing else much is available at this point in time, but the outside neurologist did a CSF and an MRI. The CSF showed 3 cells, all were lymphocytes. Protein was 26 milligram per deciliter, so that was normal, and the sugar was 89.5 milligram per deciliter. We don't have a concomitant random blood sugar available at this point. And HSP PCR was also done in the CSF, which was negative. After this, the patient was initiated on acyclovir, which was, so the MRI, this is the MRI at the time that she was admitted.
So quickly run through the imaging findings on the MR. So there are asymmetrical abnormalities involving the cortical and subcortical region of the bilateral temporal lobes, left more than right. These are the diffusion weighted sequences where you can appreciate restricted diffusion. I'm not sure if the frontal changes are artifactual or real. If you come to the corresponding flare images, in the top panel, you can appreciate that there are again edematous changes in the flare, bilateral temporal lobes involving the mesial temporal lobes and also the left temporal lobe, subcortical cortical predominance. I cannot appreciate any other abnormalities on flare, especially in the cortex or subcortical regions. There were some hyperintensities in the bilateral middle cerebral peduncles. Again, not sure if these are artifactual or real. So at this point, Dr.
I thought they were real.
Okay.
Divyani, this is the case you sent to me on email as well, right?
Yeah.
I think there was a lot of signal change there at that point, almost like well, I won't take your words, but Golgi kind of changes.
Yeah.
Right, and then because of the, she probably had gone into status epilepticus and she was initiated on multiple anti-epileptic drugs and was started on injection dexamethasone, but how much she got for how much time, these details are not available, and acyclovir was given for 3 weeks. So for over 3 weeks she was treated and no improvement was perceived, and she was shifted in this state to our center. When she was admitted, we re-evaluated her and repeated a CSF, which showed no cells. Protein was again normal, sugar was normal. Infective workup in terms of TB, fungal, and routine were not negative. We also sent an autoimmune panel in the CSF, which was negative. And the EEG showed generalized delta slowing with periodic discharges, which were long interval. And subsequently, this patient stopped having seizures, and she was pulsed with ethylprednisolone 1000 milligrams for 5 days. And after that, she was also given IVIG at a dose of 2 gram per kg over 5 days. She continued to be comatose, but no further breakthrough seizures happened either clinically or on the EEG. At present, she is nearly 50 days at admission, and her GCS is continuing to be poor. She's on a ventilator, of course, and pupils are dilated, not reactive to light, although she is breathing spontaneously. No further clinical seizures or automatisms, and EEG is just showing generalized delta slowing. We have at our center done a CT initially, followed by an MRI.
Yeah, so the CT images in May, you can appreciate that there is imaging progression of the abnormal changes. White matter abnormalities in the bilateral cerebral hemispheres, also the thalami also appear to be abnormal. Central white matter is abnormal and edematous. The MRI better depict the imaging findings. There are multiple areas of cystic degeneration. T1 hyperintensities in the cortex possibly suggestive of a necrosis over there. Coming down to the flare sequences, you can appreciate that the white matter is inhomogeneously hyperintense on both sides. Again, cystic degenerative changes in the predominantly in subcortical regions, also in the deep white matter, periventricular regions in the posterior periventricular white matter. Brainstem also demonstrates abnormal signal changes on the flare. Diffusion, we have areas of restricted diffusion involving the abnormal white matter, some focal areas, but overall the white matter appears to be hyperintense, with the cystic areas appear to be spared on the diffusion weighted signal changes. T2, again, you can appreciate the abnormal white matter, diffusely abnormal, with areas of multifocal cystic degeneration. And post-contrast study, there are some areas of incomplete enhancement and some areas of peripheral enhancement in the frontal white matter. Some areas of subcortical enhancement, but that possibly can be correlated with the T1 hyperintensity. So some area, the necrosis are already hyperintense on T1. Looking at this case, we thought of a companion case which was presented in the January session. I'll not go into the details of the clinical presentation. This child had a fever with cerebellar signs and was relapsing. Also had GCS scores with dystonic features. Again, EEG also demonstrated the generalized slowing. CSF panel was negative. COVID antibodies was positive for this case. And these are the imaging findings. There are some confluent white matter abnormalities, predominantly white matter abnormalities, but also involvement of the deep brain nuclei, restricted diffusion in the posterior cerebral regions, and also in the external of the periventricular frontal white matter. So repeat MRI again after 14 days, and you can appreciate that there is progression of the imaging findings. The deep and gray matter involvement is seen, though no cystic areas of involvement. Post contrast, some peripheral enhancement, but not very significant. So this is the T2 and flare images. White and gray matter involvement, you can appreciate that the white matter is similar to our case, but without the cystic degenerative changes. That was a case of SSPE. From literature, I could find out that there are few cases presented with cystic degeneration and SSP, but not as extensive as seen in our case. So that is one of the differences I thought of. The other possible differences were chronic encephalitis, primarily viral infections. Mitochondrial was a possibility, but the cavitatory changes are more confluent in the mitochondrial disorders. The corpus callosum involvement is also pretty characteristic, involving the middle brain if it's the predominant white matter involvement. The diffusion changes are also pretty characteristic. There's peripheral areas of restricted diffusion. So mitochondrial would be less likely, but given the atypical imaging findings, I think it can be possible. And at this point, I'll open the case for further discussion.
So Vyani, the SSP side of things you would have covered by now, right?
Yeah.
We couldn't think of anything else radiologically, guys. So,
Okay.
Vivek, if you have any ideas, Yale, Lokesh.
Can I just ask, what did he also have a EPC in the beginning clinically, or was it just refractory seizures?
It was just refractory generalized seizures. There was no real history of EPCs.
Okay, and in between the events, there was encephalopathy or no?
Initially,
In the
she
very
was
beginning
recovering.
when he started.
She was fine. She was recovering in between. But 7 to 8 days into this particular seizures happening, she became encephalopathic.
Yeah, so which is kind of interesting because if you think about the autoimmune encephalitis, I mean, normally the encephalopathy comes at the same time, and the seizure. I don't know. I don't feel this is an autoimmune encephalitis. I feel it's a different process, and also the distractions. Even how much you see on the CT would go a bit against some of the ADEM, at least not a typical ADEM that we see. So I don't know. I think there's quite so clinically now. Was there even a consideration of biopsying any of this, or?
Yes. Finally, now there is a consideration for biopsying this patient.
Because I really feel there's so many atypical features. I mean, I think the only thing maybe I would do before a biopsy, if you can get it quickly, is get the Pol-G and the mitochondrial, because I guess that's the only thing that will stop you from a biopsy.
Yes, we've sent the mitochondrial genetics. We've asked for an expedited report. And if nothing comes up on that, then we'll try to get a biopsy done on her.
Okay, and if you want us to discuss again, I feel it's very, very atypical. It doesn't, I wouldn't label it as, and these distractive changes are quite worrying.
Yes. I just wanted to know, I mean, if there is a possibility of, I mean, do we need to give her further immunosuppression, or that is not warranted?
I wouldn't escalate. I would do, before you do anything, I would probably biopsy this, at least so you're not going blind, because also the patient, it's very difficult to monitor clinically a patient in the intensive care. So it's, and I guess, I mean, it doesn't look like anything infective, but we recently had a terrible patients with genetic HLH that had this virus in the head we didn't even know existed. So I just think before you keep going, if you're anyway discussing biopsy is worth doing, and it may even be worth, I don't know if you have this available, but maybe worth sending for this metagenomics.
Yes, we were thinking of that.
Rule out an infective thing, not because you think that it's definitely needed, just so you can feel a bit more safe to escalate immunotherapy if you want to.
Correct. Yes.
So even if you don't think it's in the top of your differential, it's worth kind of doing just so you know you're not making anybody worse.
Right. Okay. Point well taken.
But happy to discuss. So if you want to discuss after the biopsy and decide, I just feel this is very, very atypical. I think that I can't see how you can get away without doing a biopsy, but. Right. But also suspect that the biopsy will show nothing it normally does. But.
That is a concern, but I don't know what else to do.
Divyani, I was going to come to that point. What will you biopsy? Because you should probably tell them the
Yeah,
target.
because seriously, I don't know. I mean, it's just
a bit of that enhancing cortex should be taken out apart from just the cyst. Nihaal, would you agree?
Yep.
But the cyst might not have
the
much.
biopsy will probably show up a non-specific inflammatory demyelination. Not sure.
Yeah, that's what I'm worried about. That's
so
why
no, but Yale's point is the specimen could then be subjected to metagenomics to pick up any signatures of the image. But where does metagenomics happen at the moment in Delhi, Divyani?
I don't think it happens anywhere, but we are trying to find out.
If you need any help with the labs here, we can line you up.
UCL do it, and I think UCSF in San Francisco do it. I don't know where else. There's a few centers in the world that do it.
Brewer would do it here at the UCL, right?
Yeah, she would. Yeah.
I can line you up.
If you could, that would be wonderful.
But check, of course, if somebody does it in India, even if it's not, as experienced, it may be better because you can get the sample there quicker.
Certainly, yes.
So maybe even somebody, if he does on a research setting, it may be worth. Sometimes sending it across the world just delay the.
Right. Yes, I understand.
Doesn't Medgenome do it in Bangalore? I'm not sure, but Dr. Kavita or anyone else.
I will speak to Medgenome also if I haven't explored that option actually. I mean,
it's technically a bit difficult and different. You might want to read the papers that have been published so far. There's one paper I think in Nature, but in terms of how it's done, it could be replicated for sure.
Okay.
You don't want to false positive either, right?
Yeah, no, that's true. That's true. But I think, the method is that because what he does, he recognizes any foreign DNA or RNA. So he doesn't specifically tell you what virus it is, but he can tell you, is this human, is it not human? And then depend on the, how much viral load they have, they basically like puzzle the virus or the bacteria back in. And in patients on immunosuppression, you should have quite a lot of viral copies because you've just immunosuppressed them. So it's nearly easier for them to do it on patients who have been immunosuppression in case it's positive.
Would it be
it's false positive if they use like gloves and somebody touched something, there's like with any, but most laboratories know how to do those things, I guess. But you can send it here. I'm sure somebody would do it. I'm just saying if somebody does it in India, I'm sure it's not the most technically, my understanding, not the most technically tested.
Short of biopsy, is there any point doing the metagenomics in the CSF?
So actually, in that one patient that we had, the metagenomics in the CSF was negative. We did it everywhere. Had this virus only been this way. It's worth doing it. And I think if for example, you had it on site, then I would say, yeah, do it. But I think if you need to send the sample to somewhere else and you get into, then you may as well just make sure you do it on the tissue. Right. But again, I think the only thing that would prevent me from doing a biopsy is if it, the POLG will come back.
Yeah. Yes. Okay.
So it may be worth trying to see if you can get that before you do a biopsy. But anything else but kind of a mitochondrial one that can really explain the whole picture, you probably need to do that.
Okay. Okay. Thank you so much.
Thank you. This is our last case. It's a follow-up case which was initially discussed in October. This case from Dr. Kavita. So Brahmani or Dr. Kavita want to present the case?
Yes, sir. So this is a case of 10-year-old girl born of non-consanguineous marriage. Second child, elder child is completely normal. Born at full term, no history of any birth asphyxia, any neonatal events during the neonatal period. But she has born at with 1.5 kg, small for gestational age, and there is no history of any NICU stay. And she has a severe global developmental delay since infancy of DQ less than 20% in all the domains. almost, and she was treated like torch till last September when she came to us for the first time in September 2021, and she was treated like torch outside, and she came to us with a complaint of right hemiparesis, sudden onset of right hemiparesis on 15th of September, without any prior history of any fever or any trauma. So this was her complaint, and we managed the stroke part, and we did the investigations to rule out the cause for the stroke. And also we thought we evaluated for the, because she was treated like a torch, so we saw the IG torch report in the mother. This happened at around 2 months of age. When the baby was 2 months, the mother's IgG came positive for rubella and CMV, and child is also IgG, not IgM, and 2D echo is showing just small ASD, and she doesn't have any cataract, she doesn't have any hearing deficiencies, although she has a corneal clouding and significant dysmorphic faces in the form of crowding of the teeth and dentition wise poor, and corneal clouding opacities with a triangular kind of face. So that was her dysmorphism, and we treated the stroke part, and we did a MRI. Sir, MRI.
Yeah. So 2 sets of MRI, one in September 21 in the acute period, and you can appreciate that there is an infarct in the left frontal parietal region. So left frontal parietal region demonstrating restricted diffusion, cytotoxic edema, some areas of focal areas of abnormalities in the genome of the corpus callosum on the contralateral side. Flare and the T2 sequences demonstrate the hyperintense foci, but if you appreciate the skull morphology is abnormal, it is slightly flattened along the posterior aspect with an almost triangular appearance on the anterior aspect. The frontal lobes are hypoplastic. There are also a dysmorphic appearance of the lateral ventricles, especially the frontal horns, and also the basal ganglia due to the dysmorphic appearance of the lateral ventricles. Corpus callosum is also dysplastic and dysmorphic. Brainstem also is hypoplastic with slightly elongated medulla, altered brainstem ratios. I could not appreciate any structural malformation in terms of particle malformations or heterotopias. SWI did not demonstrate any hemorrhage or mineralization. The MR angiography, you have the narrowing of the terminal ICAs with a almost straightened appearance of the middle cerebral arteries, some tortuosity of the anterior cerebral arteries, but you can appreciate that the bilateral middle cerebral arteries are pointed vertically, obliquely, rather than a normal horizontal demonstration, and there is terminal ICA narrowing. Child came for a follow-up MRI in June 2022, and there is
well, the child had improving the right hemiparesis part, and we thought of some genetic etiology because of the dysmorphism and severe wasting hypotonia. What could be the cause for the SGA during the time of birth and all? So we did a genetic testing after counseling because there was a financial issues were there, and genetic test. Yes, and we repeat also.
Yeah, I'll just show the images and we can go to the genetics. So chronic changes of ischemia in the left frontal regions and parietal regions. Again, dysmorphic brain. No new abnormalities, no acute abnormalities. Again, the angiography appearance is pretty similar to what we have seen in the first scan. This is a control. You can appreciate the normal orientation of the middle cerebral arteries and the intercalateral arteries. No abnormalities in the neck vessels. At that time, we thought of differentials of ACTA2 mutations and MYH11 mutations given the abnormalities of the corpus callosum and also the intracranial arteries. Yeah, Brahman, you can go ahead with the genetics.
So the genetic testing showed UNC UNC80 positive, and we did the reverse phenotyping whether she is matching with the phenotype, and she has definite. Here this UNC80 showing infantile hypotonia with the psychomotor and characteristic faces, and she has a normal or we can say mild hypotonia, but the hypotonia is not very significant like in UNC80, and she has severe wasting. She has a corneal clouding which is not explained in the literature of the UNC80, and she has a stroke-like presentation. Again, that is not explained by this genetic mutation. Only thing, she has a characteristic faces, but none of these babies have corneal clouding. Even though their faces and the teeth crowding were there, and she has a mild hypotonia.
Okay. So imaging wise also it does not match.
Yes, sir. Actually,
imaging findings do not match with the UNC80. They usually present with normal appearance or slightly atrophic changes in the brain, but no structural abnormalities, no intracranial abnormality, intra-arterial vascular abnormalities have been published in literature. There are no collaterals at this point, so it doesn't fit into the criteria of Moyameyer disease.
Sir, last time collaterals were there actually.
I cannot appreciate them.
And also CT also suggested at one area there was a left frontal calcification, small.
That can be dystrophic calcification.
Okay.
Dr. Manka, anything on the imaging, the arterial appearance?
No, I think, yeah, there might be some collaterals there, but that's all right. It's expected. So much occlusive vasculopathy, and I was just trying to figure out if this gene mutation does have a vascular underlay that has not been described previously. You might be wanting to describe that if it's such a pathogenic mutation.
No, sir. Stroke-like presentation or any arteriopathy is not described in any literature of this UNC80 gene.
Yeah, no, what Dr. Manka is saying, this could be the first case if it clinically matches.
So actually, clinically, only few features are matching, not all. And the typical description that has been given, all the features are not really prominent in this child, and especially the corneal clouding, which is very prominent in this girl, has not been mentioned here, but that may be additional features which keep getting added to any kind of mutation. So we are awaiting the parental testing, and after that probably we'll have a more clear idea whether this is really pathogenic. So we actually wanted your comment on the comparison of the previous, vessels with the present one. Is there any progressive arteriopathy, or is it improving, or is it the same?
So here you can see that there is some there's narrowing of the bilateral ICAs, terminal ICAs. In the follow-up scan, the right ICA is slightly improved, but there is still some narrowing along the left ICA. So it is not a progressive arteriopathy. I would call it more as a stable or slightly improved in appearance.
It's possible that the vessels are just dysplastic rather than labeling them as a any arteriopathy.
No, vessels are definitely abnormal in terms of the orientation. So that can be related to the vessel, the walls of the vessel, if they're abnormal or not, the intima media. Because they are typically seen in these mutations, but they have obviously come out as negative.
Yeah. So once we get the parental testing, if it is proven that this is pathogenic, then probably we'll add these. We'll publish it then. Yeah.
Sure.
Thank you. Thank you so much.
All right. Thank you. And